I think ma'am, sir has lost us.
Yeah, I think. So we have not started, right? Not
No.
started.
We have encountered.
We are live.
Satyan sir, I think
Yes.
we got disconnected with you in between for some 10 seconds, 20 seconds.
Yeah, I think कुछ थोड़ा सा unstable का आ रहा है. Just try.
So, if you're okay, ma'am, should we start with the session or?
Yeah, we can start.
Yeah. So, good evening, everyone. I welcome you all on a yet another NNF online education and learning session. So, today we have a topic on neonatal airway disorder diagnosis and management. And as a speaker, we have Dr. Nitya. She's a pediatric ENT and the airway surgeon at Rainbow Children Hospital, Chennai. And Dr. Girdhar has specifically requested ma'am to take up this lecture. And for moderating this session, we have Dr. Satyan K. Himrajani, sir. Sir is a senior consultant neonatologist at Mahatma Gandhi Medical College and Hospital, Jaipur. So over to you first, Satyan, sir, and then we can proceed with Nitya, ma'am, further.
So good evening, everyone. I think this is a very upcoming thing as we've talked and airway disorders. As we see that we have to really look into any baby in a holistic manner. And although we now have very many neuroprotective mechanisms as well as lung protective mechanisms while we are ventilating, but are we also ventilating the baby with airway protective strategies? That is very, very important. So any baby who is getting a tube can have complications related to that in the airway, as well as whenever we are resuscitating a baby, we may face certain challenges where we are not able to intubate. So, if our mind knows at that stage what to do, who to call, and how to take help, that will be very, very relevant for us who deal with life and death in just a matter of seconds. And airway is such thing which, if dealt properly, can make a difference. So I am looking forward to this lecture by Dr. Nitya, who's a pediatric ENT. We'll see her perspective and the latest upcoming things in the treatment of these airway disorders, in specifically in neonates. Over to you, Dr.
Thank you, sir. Yeah, as I told you, airway disorders in neonates, it's really coming up, and also it's a really vast topic to cover it in actually 1 hour, because each part of the airway is like it should be dealt separately. I feel so. I'll try to cover as much as possible. I'll show you the pictures and the videos, like how they present, so that you can relate clinically, and then it will be useful for your clinical practice as much. And thank you for the for this opportunity, and I thank Girdhar sir for this opportunity. The first time I'm presenting in a non-ENT place, so I think I'll go directly to my presentation. Can you start, ma'am? Can you start, sir?
Yes, ma'am, you can start.
Sure. So, talking about airway, airway is not just lungs, trachea, but airway starts from the nose, the nasopharynx, the oropharynx. Then comes the larynx, the trachea, and lower down is the bronchi and the lungs. So, mostly as a pediatric ENT, I deal from problems dealing from the nose till the bronchus. So, nose, most commonly what we see is, even though all these conditions are rare, but since in a pediatric specialized hospital, we get exposed to these conditions. Nose, mostly two conditions, I would say. One is choanal atresia and piriform aperture stenosis. And in the oropharynx, there can be valvular cyst or any collections or venous swelling. And larynx, the most common cause everybody would have heard about is a laryngomalacia. a laryngeal web, subglottic stenosis, and a vocal cord palsy. Trachea, tracheomalacia, tracheoesophageal fistula, and tracheal stenosis, and bronchiomalacia, basically. And as you see, the prevalence, the most common is the tracheomalacia, which is around 60%, followed by vocal cord paralysis, followed by a subglottic stenosis. So as an ENT, when I get called for a child with any respiratory distress, what I normally see is the grade of respiratory distress. So whether it is just a noisy breathing, but the child is active, the child is like, there's no feeding abnormalities, the child is feeding well, or there is some problem. There is grade 2 when it comes to, there is some free feeding issues, the child is little lethargic. And the grade 3, the child is really exhausted. And as you say, respiratory distress, most of them, they present with dyspnea, they are present with stridor. There is no stridor. The child is really exhausted. So next, I would like to know, after grading the severity, to know how much invasive should I go. Then next is the cause and the site. We try to narrow down on the cause of the airway obstruction and the site of airway obstruction. So how can we do that? So 4 things we need to see for that. One is the quality of the pathological respiratory sound, that is whether it is low pitch, high pitch, and what part of the respiratory cycle the pathological sound is produced. Then the 3 assessment of the functions of larynx, and then the medical history. So when you talk about the quality of the respiratory cycle and the phase of the respiratory cycle. So when it comes to the quality, the low pitch sounds, the stutter or a snoring, it usually arises from the nose or the nasopharynx. But when you see stridor and even wheeze can come from lower airway. When there is an intrathoracic obstruction of large tracheobronchial airway, there can be even a wheeze. So you can just see this video. You can see this is a typical inspiratory stridor caused by supraglottic obstruction. There is some obstruction above the glottic level. So it is a high-pitched and it is an inspiratory stridor. But when you see this child, it is a typical biphasic stridor. So we know there's some problem in the vocal cords or in the subglottic level.
Dr. Nitya, is there some sound also in this video?
Yeah, there is sound. It's not audible, sir.
We can't hear that. Sorry.
Not now, sir.
No.
Audible to me. Not audible.
Okay. Anyway,
Okay.
please go ahead. If possible, we'll try and
Yeah, sure. So the respiratory function I have already dealt with. Now next is the voice. So when a child cries, we see whether it is hoarse. Hoarse means there is some weight over the vocal cord. There is some additional stiffness over the vocal cord. So it may be a vocal cord lesion, or it can be a vocal cord tumor, or whether it is weak or breathy. That means the vocal cords, there is some the vocal cord is not very stiff. So it may be in the case of a vocal cord palsy, mostly unilateral, or it may be muffled when there is a supraglottic lesion. And when there will be, it may be high pitched, as in bilateral vocal cord palsy or in a, well, I'll be dealing with each condition, so you'll get a good idea about it. And next is the sphincteric function. That is when the child is swallowing, is there any history of any aspiration, any choking, gagging, or any history of any aspiration pneumonia or any patch in the lung? In these cases, you know there is some communication between the airway and the esophagus. So it can be a vocal cord palsy, where there can be aspiration or there can be cleft. I'll deal with these conditions. or that can be a tracheoesophageal fistula, or even in some neurological child with HIA, they can have some the laryngopharyngeal dysfunction, maybe neurological. So coming to the medical history, so in general, we ask all those antenatal, prematurity, and the Apgar score, whether there's any birth injury. Added with it, we ask the pathological sound, the age of onset. If it is at birth, then we know there is some fixed narrowing for sure. So it can be a vocal cord, and it is significant. And any other, like, we say laryngomalacia, it's a benign thing. We can wait. So any spider at birth, we should not wait. There is some airway abnormality which should be, the child should be scoped and seen for the pathology. It can be a bilateral vocal cord palsy, vocal cord, a subglottic cyst, or a laryngeal web, or any mediastinal abnormal vessels compressing the trachea. If it is developed in the first, second week, or the third week, then we can tell it can consider laryngomalacia. 1 to 4 months, if the child develops a stridor after 1 month to 4 months of age, it's mostly a moderate degree of subglottic stenosis or a subglottic cyst. Then what causes the aggravating factor? So a stridor, if it increases on feeding or crying, so that means when there is an extra need of air, if the stridor is worsening, so in that case, it can be a fixed obstruction like a bilateral vocal cord palsy, subglottic stenosis, or a subglottic hemangioma, or can be laryngomalacia. If it is increasing during sleep, it can be a nasopharyngeal or an oropharyngeal pathology, or it can be even tracheomalacia can aggravate during sleep. And if there are some choking episodes, as I already told you, there can be a communication with the esophagus. Then body position, where the lesion is located. Is it better when the child is prone? So glossoptosis. Glossoptosis is a condition which is mostly seen in kids with peri-Robin sequence. They have the tongue, which is actually like compressing onto the posterior pharyngeal wall. So they feel better when the child is in the prone position. Or vocal cord palsy. If it is a unilateral vocal cord palsy, what happens is, if the child lies on the side of the unilateral vocal cord palsy, that is, if the child has a right vocal cord palsy and this, you put the child on the right lateral position, the symptoms will be much better. And also any cyst or mass. If you put the child on the side of the lesion, the symptoms will be better. So in general, when we see a child, we follow the specs. We follow the specs protocol, which says the severity. We ask the parents for the severity of the breathing difficulty, so that we know better, because mother is the best person to ask. And also we see the evolution of the obstruction over time, whether it is progressive or whether it is static, or whether there is any problem with the feeding, whether there's any history of aspiration. Or next is the cyanosis. The child is developing cyanosis or any change of color. That means it's really significant. And last is the sleep, whether it is the sleep is disturbed, or there is any retractions, or so we get to know the severity of the distress. So before we go to each condition, I would like to raise this poll. So we can just use the annotations and mark it. Cause of stridor at birth can be all except. Any idea, anybody? You can just mark on it.
You can put your answers in the chat box.
Tracheomalacia. Okay. A, B. Okay, B. Subglottic stenosis. Okay, yeah, good. So The answer is actually C, laryngomalacia. As I told you, laryngomalacia never presents at birth, but we'll be dealing with conditions, and I'll show you the videos also about this condition, so you know about it better. So bilateral vocal cord palsy will cause inspiratory stridor, expiratory stridor, biphasic stridor, or a stutter. Okay, sure. Okay, so the answer is C. It's a biphasic stridor. So anything in the vocal cords or below the subglottis, it will cause a biphasic stridor. Can prolonged intubation cause subglottic stenosis in a neonate? I think this is a very significant question. Yes, 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 yes. Yes, of course, it will cause. The only difference is usually in older children, you limit the number of days to 5 days. But in neonate, you can tube them for 2 weeks, 3 weeks without a subglottic stenosis. The duration is little more. This is the last question. Voice can be normal in unilateral vocal cord palsy, bilateral vocal cord palsy, vocal cord cysts. A, B, C, D, E. Yeah, so the answer is bilateral vocal cord palsy. We will come to each of this. Okay, so I'll deal with each condition. So you're just familiar, you just become familiar when you come back, when you see it the next time. And also I'll tell you grossly the management for each of this. Okay, I don't know how many people have come across. I just put this child because we had this child who presented to our OPD with complete agenesis of the nose. Okay, it's usually associated with trisomy 13 or 21. And as you know, this condition is very, very, very rare. So the management for this condition is sometimes it's just the bony part of the facial skeleton will be formed. It's just the cartilaginous part, the external part of the nose is not formed. In that case, the management is very easy. We just open up the nose, the child can breathe through the nose, and maybe we can do a plastic reconstruction later. If it is associated with malformation of the facial skeleton, then the child will need an airway just for, we'll just keep an airway for breathing. But otherwise, the child should have facial-maxillary procedures, multiple facial-maxillary procedures. So this is the pyriform aperture scenery. It is not very rare now. We've seen it in few kids. So as you see in this CT, this I've got it from the net, the CT. So you see this is the bony skeleton of the nose. Above this, the cartilaginous framework of the nose comes and it just protrudes out of the face. So this part, okay, this is a nasal septum and this is the lateral wall. So this area is actually stenosed. So the nasal cavity is actually narrow. You see this? The nasal cavity is actually narrow. So what we do for this is, this is a balloon. You see the balloon. We introduce it into the nose and we cause microfracturing. Okay, you see, we have done cases of this, but this is the balloon we use and we put it into the nose and we cause dilated. We put distilled water into the balloon and we dilate it and we cause microfracture of this bones. And we just dilate the area so that they get an airway and we stent it for the next 2 weeks. So this is a child with choanal atresia. So we know all neonates are obligate nasal breathers, but you see this child, how nicely the child is breathing through the mouth. Okay, and this is a child after the procedure. Okay, you can see the misting in the nose. Okay, so this is what happens in choanal atresia. So you see the buccopharyngeal membrane. Buccopharyngeal membrane does not break. So there is no communication between the nose and the nasopharynx. So it's mostly associated with Down syndrome or any craniofacial abnormalities, but or as an association of Char syndrome. But it can occur as an isolated condition also. And this procedure we do, it is totally endoscopic. We have nasal endoscopes and we have small instruments through which we just we raise a flap over this choanal part and we just drill off this bone. Okay, so this is a child who presented, who had some stutter, some breathing difficulties. When we scoped the child, we saw a cyst in the oropharynx. And this was like a dermoid. It was just some retention cyst which had developed. Okay, and this is a small procedure. It's this also done endoscopically. Okay, now you come to the next most common congenital laryngeal anomaly, that is a laryngomalacia. The onset, as I told you, laryngomalacia, most conditions never present at birth. Ideally, it presents by around 2 to 4 weeks of age, and it by before 2 years of age, there'll be a resolution of this condition also. It is associated with reflux in almost 80% of the cases. And almost in 80% of the cases, it will be mild to moderate. That means there'll be no failure to thrive. There'll be adequate weight gain. There'll be no feeding abnormalities. There'll be no choking There'll be no choking. And there will be only minimal retractions in the chest. In those cases, we observe. So when we scope the child, this is the abnormality we see. You see, this is the larynx, and this is the arytenoids, which is actually closing. Okay, and this is the epiglottis, which is actually folding over. And you see the aryepiglottic fold, this fold from the epiglottis to the arytenoid, it is actually short. So when there is an inspiration, the arytenoids get pulled in, and because the AE fold is short, the epiglottis also folds over. So the procedure, what we do for this condition is known as a supraglottoplasty. As I told you, it's only in moderate to severe cases. We release the aryepiglottic fold. Okay, only the mucosal part so that there is no bleeding. And we just remove a part of this cartilage. This is the cuneiform cartilage. We remove the part of this cartilage. And this is one of the most gratifying surgery. This, you can see the retractions of this child. This is an isolated case of laryngomalacia in a neonate. Sorry. Okay, I'll just go to the next condition. So the next condition is unilateral and bilateral vocal cord palsies. So you can see this. You can see this video. In this, you see the bilateral vocal cords. It is not fully opening. So you can see some small movements. That is because of the Bernoulli's phenomenon. That is when both the vocal cord is lax. So when the air moves, it just sucks the vocal fold because it is there is no nerve supply to it and it is lax, but it is not abducting fully. And also the normal position of the vocal cord, which is known as the cadaveric position, it is actually the little away from the midline. Okay, so that is why I told you in bilateral vocal cord, the cry can be normal. So if you go for a delivery and you feel the cry is normal, or or it can be high pitched, but most of the conditions you will not be able to recognize it and the cry will be normal. But child can have a bilateral vocal cord palsy. So you go for a delivery and then the cry is normal and you take the child can develop a respiratory distress. Okay, that may be a cause of a bilateral vocal cord palsy. you see there is only very little space. So what happens in a bilateral vocal cord palsy, and the prevalence is around 50% of all vocal cord palsies. What normally happens is the airway is narrowed. So in case a child wants any extra air, that is while feeding, once they start, they will be okay at birth. The cry will be normal, and they will shift it to mother's side. And when the mother starts to feed, what happens then, they need the extra air, so they can develop some apneas, they can have some feeding problems, and then that is when this will present. Okay, and bilateral vocal cord palsy, there is history of spontaneous resolution also. Almost for 40% of the bilateral vocal cord palsies undergo spontaneous resolution by around 1 year of age, or by and around 10% they completely resolve by 5 years of age. And this is a case of a unilateral vocal cord palsy. So you can see this is the left cord, this is the right cord is moving. Okay, this is a case. Okay, so how do you manage a bilateral vocal cord palsy? So bilateral vocal cord palsy will need an immediate airway. So child can be tracheostomized. So this is a child we had tracheostomized as a neonate. And now the child, once the child is around 1 year of age, then we'll do a definitive procedure if there is no spontaneous resolution. This is a case of unilateral vocal cord palsy. So what normally happens is, in a unilateral vocal cord palsy, the opposite cord compensates. So the chance of aspiration, or if their cry is weak, which is not a very important thing in a neonate, but if there is recurrent aspiration pneumonias, or if there is any if there is any history of any recurrent choking episodes, we have to manage this unilateral vocal cord palsy. Otherwise, unilateral vocal cord palsy, normally, how do you manage is with some thickeners, milk thickeners, or special positioning, they usually do well. And this is a child with a bilateral vocal cord palsy, but the parents were not willing for a tracheostomy. So what we do is we remove the part of one cord. Okay, you see this part, and the airway is opened up. Okay, now we come to the subglottic stenosis. That is just below the vocal cord. The cricoid ring is there. The cricoid ring is thickened either congenitally or post-intubation. That is the most common cause of acquired stenosis. So you see this is the both vocal cords. We can see the subglottis and the narrowed segment here. Show you one more picture. Okay, this is a vocal cord, and you can see the stenosis. Okay, this is the third common laryngeal anomaly, and this is the most common cause of laryngeal anomaly, who will end up in a tracheostomy tube. And if you have to, when we do a scopy and we size the airway to know whether it is normal or whether these are all severe cases, so you can actually see it. Now, what normally we do is we put an endotracheal tube and size the airway. So if in a preterm neonate, if a 3 mm endotracheal tube is not able to pass, we say the child is having some degree of subglottic stenosis, or in a term neonate, it is a 4 mm. So how do you manage this subglottic stenosis? In neonates, mostly we treat it conservatively endoscopically with balloons. So you see, we introduce this balloon and we fill the balloon with distilled water, and we actually ventilate the child well, and then we do it. So we get some apnea time. Okay, you can see this getting filled with the distilled water. Okay, and then you can see this, when you remove the thing, this is actually opened up better. Okay, we do 2 to 3 sessions of this. Okay, the next anomaly is a laryngeal web. So unlike a subglottic stenosis and a bilateral vocal cord palsy, this laryngeal web Okay, you can see this is a laryngeal web. So this is a vocal cord. There is a web between the vocal cord and there is a small airway. Even the airway is small, laryngeal web, they usually do well. Sometimes it may be an incident finding also when they become adults, when they go for any GA procedures. Or some of them can present with low, feeble voice, a weak cry. Okay, this is a case of a laryngeal cleft. Laryngeal cleft means there is a gap between the airway and the start of the esophagus. Mostly it's associated with microdeletions in 22q11 chromosome. And this is a very rare anomaly. And mostly these kids, they present with aspiration pneumonia, recurrent choking episodes. Okay, you can see this is the vocal cord and this is the posterior glottic space. So this is the arytenoids. There should be an interarytenoid area which is closed. You can see this interarytenoid area, it is actually deep. And we have different degree of cleft. First degree, it just reaches the vocal cord. Second degree is goes below. And we have lower down passing the cricoid, even till the trachea. That is a grade 4 cleft. So this is a case of tracheoesophageal fistula. So as everybody knows, there are different types of tracheoesophageal fistula, and they mostly present with once not diagnosed at birth, they usually present with recurrent aspiration pneumonias or patches. So you can see this area, that is the area of the tracheoesophageal fistula. So we had one child who presented to us with multiple episodes of pneumonias with multiple patches in the lung. So we did a scopy, but there was no clear-cut area of a fistula. So we had put a methylene blue dye into the orogastric tube and we withdrew it, okay, to see the dye flowing into the trachea. Okay, so we could, it was a very small fistula. Okay, that's how we were able to make it up. Okay, this is one common condition now, which is normally seen as like so many preterm babies are surviving and like they're coming. A lot of preterm deliveries are increasing. So tracheomalacia and bronchomalacia, it's defined as when there is more than 50% collapsibility of the trachea. And it accounts for almost 50% of the congenital tracheal anomalies. So the hallmark feature of tracheomalacia is the expiratory phase of the respiration is increased. And also during feeding, there can be choking episodes even not even while feeding, even crying, there can be history of apnea, choking, and all. But in between, what will happen, they'll have severe choking episodes, and in between, for some time, they'll be really normal. But even in the normal periods, there will be an audible expiratory wheeze. So that is a hallmark of this tracheomalacia. And some kids with tracheomalacia, like any preterm baby who has been tubed, when there is an associated like tracheomalacia, there can be difficult extubation also. So this is the vocal cord. We are going in. So in this, you see the anterior and the posterior wall, it's actually completely collapsing. So this is a posterior wall and this is the anterior wall. And there is a small pulsation in the anterior wall. It's fully collapsing. So this is the area of the tracheomalacia. But you see, even the posterior tracheal wall, which is made up of the trachealis muscle, it is actually completely coming and touching the anterior tracheal wall. That is because the tracheal rings, the C-shaped tracheal rings, is not fully developed. Usually the tracheal ring, if this is a tracheal ring and this is the trachealis muscle, the ratio will be around 5 or 4:1. But for these cases, it will be it will be really less, like 2:1. So the amount of posterior trachealis muscle will be more. And even if you see, when you're going into the bronchus, okay, the bronchus is fully collapsing. So this child will need some positive pressure unless the child, this is a preterm child. So unless the child gains weight, will need some positive pressure to keep the airway open. They can go on a home CPAP. You can see the full collapse. Okay, so we do a scopy and you find out one anomaly. So is that it? So no, whenever you do a scopy, you have to see the nose, the nasopharynx, the trachea, and the bronchi. So this is a child we scope with a stridor. You can see this is a vocal cord. There is a subglottic cyst. But when you go down and see, this is a subglottic cyst. When you you can just see in the anterior tracheal wall, there is a small pulsation. That is the pulsation here. That is the innominate artery, aberrant innominate artery pulsations. But when you go down, you see the trachea is normal. So that is an area of tracheomalacia, which is due to the compression of the innominate artery. So complete tracheal rings. So that means the trachea is normally formed by C-shaped cartilages and the posterior part of the trachea is formed by the trachealis muscle. So complete tracheal ring means the cartilaginous, the tracheal cartilage is not C-shaped. The full tracheal ring is made of cartilage. So what happens? These kids, they will have first of all, they'll have stridor from birth. They'll have always they'll have a wet cough. There will be poor mucociliary clearance, and their lung will be really bad. Like you can see the trachea. It's so round because it's a case of a complete tracheal ring. Okay. In this case, we have to do an open procedure. It is known as a slide tracheoplasty. So if infection can cause an airway problem in kids? Yes. This is a neonate who presented to us with an eye swelling and this is actually a osteomyelitic area. So this is because of the maxillary sinus infection, and we could drain so much of pus from the maxillary sinus area. And this we go endoscopic and do the procedure. We open the maxillary sinus and the medial wall of the orbit. Okay, how about tumors? Are tumors common in children? Yes. So this is a child. I think this is the first case of a first branchial pouch anomaly. So this we had like where I did my fellowship, we had a airway team, difficult intubation team. So we got called in that day because of difficult intubation. This child had a lymphatic malformation below the tongue and also a teratoma in the oropharynx. You can see this picture. Okay, there is a tumor in the oropharynx inside. Okay, so that tumor, it didn't allow the medial wall of the oropharynx and the nasopharynx to develop. So once we remove the tumor, we can directly see the inner part of the ear. So this is the inner ear, that three bones, malleus, incus, stapes of the ear. That when we put a scope into the mouth and we turn it laterally, we can actually see the inner surface of the ear. Okay, so this is the first case of the branchial pouch anomaly. So this is a child with the cystic hygroma who presented to us, and the child is on a tracheostomy now and undergoing sclerotherapy. Yes,
Dr.
sir?
Nitya, if I may ask, how did you intubate it in such a situation? What procedure was used for difficult airway management?
Yeah, so the thing is that because the tumor was very solid, like any like we couldn't do anything with a flexible or anything. So what we did was we introduced we have a rigid endoscope. It is 15 centimeter and it is 2.7 mm. So we introduced the endotracheal tube through the rigid endoscope, and we could manipulate it. It's a rigid, it's a rod-like thing. So we could manipulate it through the tumor and reach the larynx and intubate the child.
And any role of in such situations, any role of LMA if that can be inserted or so?
The LMS, actually we couldn't make out like correctly where is the epiglottis. So there is a big, like one big teratoma sitting there. We couldn't actually make out where is the epiglottis. So we somehow saw some vocal cord, and it was all the epiglottis, part of the epiglottis was all into the tumor. So we could see the vocal cords, and then we just, with the rod shape, because it's rod, we can actually push the tumor and go inside. We could like a railroading thing. We just put it in. We just introduced the endotracheal tube into the endoscope, and we just inserted it over the cords. Okay, sir. So normally, like anesthetists, they intubate only in such cases like where you need a rigid scope to manipulate. We go and intubate. So, yeah, there are lot of child with HIE sequelae. So, in such cases, when to start a feeding, when to not start a feeding, when to go for an alternative procedure. So, we do something known as a FEES, that is functional endoscopic evaluation of swallowing. So, in this, we give milk in a small syringe, and we see how, when we see the larynx, we see it is actually dry. There is no pulling. Uh, the secretions are getting cleared. So once that we confirm it, we give little amount of milk and see whether the child is swallowing well. You can actually see the milk come through. Yeah, the milk is coming, and it is, the larynx is protecting well. So you can actually start feeding slowly in this child. But if you see this child, you can see a frank aspiration. Even like a child is not fed anything, but the whole secretion is going into the larynx. So this is an unsafe swallow, and this child will for sure need a feeding procedure.
So in this is done while the baby is swallowing.
Yeah, so this is where the baby is active. So the all scopies which I showed, except for the procedures, we do while the child is like normally swallowing and everything. And this first picture which I showed is the baby is actually swallowing. Yes, we take a 5 ml 2 ml syringe and put a little milk into the baby's like in between the gums, or we just put it into the mouth, and the baby will swallow, and we can see the milk go through. So we know when to start a feed and when not to stop. And like, if there is some history of aspiration or anything, we wait and see. And in this slide, you can see the child is fully aspirating. Even the secretions, child is not able to swallow. So there is no point of giving feeds and see whether the child will be able to swallow. This child will definitely need a feeding procedure. Okay, here I think I've dealt with few of the conditions which I've seen, and the management in a short form. Any doubts anybody has?
Oh, it was just a second. So I think that was very comprehensive. But from basically from a neonatologist point of view, I would like to have a highlight on what are the indications. Like suppose a baby has been ventilated for 1 week, 2 week, 3 week, we extubate, and suddenly this baby starts having stridor or so, with some lung signs also, which keeps on coming in the X-rays or so. So we are sometimes at loss whether it's an airway problem or it is minor airway problem which can be dealt with medications, or we have to go for a bronchoscopy. There can always be, because of certain aspiration, micro aspirations and all, we can see certain X-ray findings also. So that also sometimes comes as VAP. So that's one very big confusion for us. When should we call an ENT colleague and think about seriously about bronchoscopy or the other thing? Second question that I have you now, we have other modalities also of CT scan where it can do virtual bronchoscopy also. So obviously we know that a dynamic study like a bronchoscopy will be better than CT, but there are many conditions where CT can be uh, equally good as a bronchoscopy. So if you can elaborate on those clinical features as well, that will be very enlightening.
Yeah, sure, sir. Like even I get call like maybe the child is on ventilator for a long time, you're not able to come down on this ventilation, or the child is step down to a CPAP or a high flow, but then not able to wean off fully. So the child is not able to, you're not able to send the child home. That will be those calls I get commonly from my NICU team. So what normally I do is we have to scope and see whether there is any airway pathology. That is for sure. Mostly I do the scopies in NICU itself. So we get a dynamic picture. So we know whether there's any problem in the nose, nasopharynx, and how is the epiglottis, and how is the vocal cords, is the vocal cord moving? And when you introduce a scope, we have different diameter scopes. We go with the lowest, and then we see if there is we feel there is some subglottic narrowing or something. I just put a small tube and see whether the tube is going past well or not. And even tracheomalacia, it's better to do when the child is awake without an anesthesia in the theater, unless for conditions like if you're suspecting cleft, or if you're suspecting a fistula, maybe you will need a proper anesthesia for a procedure. Otherwise, most procedures here we do it in the NICU bedside. So
Oh,
it's
my question is like, suppose we extubated for the first time and this baby developed a mild stridor and some lung findings. So obviously we'll try medically to manage. But at what point, like if it is two or three extubations that have failed, at what point would you like to come in?
yeah. So
We, yeah.
yeah. So it depends if the child is preterm
Mhm.
or a term. A term baby, if the child is needing an intubation, then I think that is exactly when an ENT person should be called, especially if there is a stridor, or if it child is a preterm and like really early preterm, like 24 weeks, 26 weeks, and there is some you suspect some lung pathology along with it, then maybe you can wait for some time and try the medical management. And then if there is any inspiratory stridor or a biphasic stridor, an ENT person should be called, even if it's a preterm, even if it is a single extubation failure.
All right. So I think that message is very clear from you that
Yes.
if it is a stridor in a term baby, it needs to be evaluated by an airway person, right?
Yes,
And
yes.
if it's a preterm with a lung pathology and failed extubation, then we can wait and call you after some few
Yeah,
episodes
few episodes.
repeated.
And if only the added sound you hear, it is mainly expiratory.
Right.
Then, but if it is an inspiratory or a biphasic, even in a preterm, the airway should be scoped and seen.
Okay. Second question, many parents do not agree to bronchoscopy for various reasons. Okay. And we have facilities of CT. So, what would be your take on this? Where we can safely go for a CT and a virtual bronchoscopy? Because CT also gives us a good idea about the lung conditions also, which can be coexisting. So sometimes it may be, beneficial as a good evaluation of airway as well as the virtual bronchoscopy can give us some idea. Whereas a bronchoscopy usually is limited to the airway only. We cannot get an idea about the lungs.
Yes,
So
yes.
in those conditions,
Yes, so CT will be mainly helpful if the child has having a lung pathology and associated tracheomalacia and with some expiratory sounds. We want to rule out any aberrant artery which is pressing onto the this thing, or any cardiac things which is compressing on the trachea and the bronchi. But the child, again, if the child, we cannot assess the vocal cords, we cannot access the vocal cords. And even the subglottis, when you, even I've seen CT subglottis, they've mentioned as a trachea, some narrowing. And unless, even when we put, even if you use a flexible bronchoscope, an examination with a rigid bronchoscope and examination with different sizes of ET tube will correctly give the size of the subglottis. So that is very important. And even in case of laryngomalacia or any neuro incoordination, some kids, they'll have some incoordination, maybe a term child, but also, but there may be some neuro incoordination between will be there between the larynx and the pharynx. In such conditions, if the child is coughing too much, there's having a brassy cough always, especially the first 1 month of life, then CT may be normal. But even if a CT is done for any, so we can see something which is like, extra thoracic compression in a CT. But if you want to do the dynamic airway, if you want to know a vocal cord palsy, all those in laryngomalacia, all those things, a scope will give a real-time picture.
so one is laryngomalacia, where definitely bronchoscopy holds an edge as compared to CT, right?
And yes,
And
vocal cord
second
palsy.
is vocal cord palsy. And how do we clinically judge whether this and neuro coordination problems also? You elaborated very finely that there also a bronchoscopy will be much better than a CT virtual bronchoscopy. And you have elaborated upon those that unilateral vocal cord palsy and bilateral. How do we differentiate? I think clinically also you elaborated on them very well. So that is probably well explained. Uh, Another, I don't see any questions, so I am probably putting up my questions. Is that fine, Dr. Kunjana? I don't see any questions in the chat box.
Yes, sir, you can go ahead, sir. Not an issue.
All
We
right,
have time, sir.
all right. The another thing is this Pierre-Robin syndrome and all, where also there is an airway problem, and again we have issues where we have to go for a surgery, which is sometimes the maxillo,
Yeah, max wax.
yeah, MDO or
The
the tongue
maxillary.
lip.
Yeah, yes.
Yeah, the tongue is attached to the lip.
Yes, yes.
So, what are the benefits of them?
So so one thing is in
Or,
neonate especially, if
yeah,
the child is having severe retronantia with the glossoptosis, one thing what we do is like we use a customized nasopharyngeal airway. We don't have nasopharyngeal airway for neonates, but then we just customize it and then use it and see if they are okay. Just to we put like through the nose, we just till the tongue base is covered, we measure it with a flexible laryngoscope, and we customize and see whether the child is okay with it. And if the mother is able to manage it, only what they need to do is they need to just suction it intermittently so that it remains patent. Or the other option is so the tongue lift you said, or there will be maxillary mandibular advancement which the maxillofacial surgeon do. But for that, the child will have to reach a specific weight, and it's not a simple surgery. And there is also some criteria according to them in which they do it. And the other if there is if it is really severe, the only option is a tracheostomy till the child gains weight, until they max fax get the child to their weight and they are able to proceed with the surgery. But the tongue to lip stitch you were telling, so for many people it is like many kids it's actually worked. if
So,
if the
so
child
that's
not
possible.
tolerating the
Yeah.
if the child not tolerating the nasopharyngeal airway.
So that's possible in a neonate also, whereas the maxillary
Yes,
surgery is
yes.
possible in a later age only.
Maxillary surgery agent, yeah, they need a definitive. I'm not sure of the criteria, but they need a specific weight, and so that they cut the mandible and advance it forward. And
Okay. And that's very interesting, the customized nasopharyngeal that you're saying. Uh, that's really interesting. We'd like to have some more thoughts on that maybe later. Uh, One question that has been asked is how to identify retrognathia, any measurements?
so it is basically a CT. Whatever is they say it's that underbite. Like how behind your mandible is. I'm not very sure of how to measure it, but it is usually like a CT they measure and then they see how much it should be advanced. Basically, this thing. But the lip to tongue attachment that we do, it's just a stitch you put so that the tongue gets forward, and we see with the flexible scope how much the tongue is coming forward. So we can just pull it accordingly.
Okay. One question that I had was regarding subglottic stenosis. You mentioned in your presentation that in term babies, if we cannot intubate with a size 4 tube,
So actually it's 4 mm size, sorry. 4
4
mm
mm.
size, 4 mm and 3 mm size. The
So
airway size should be 4 mm and 3 mm.
4 mm.
Uh,
So I understand that we do intubate a lot of babies with 3.5 size tube also, term babies. And we usually do not take them as subglottic stenosis. And I just read it somewhere in an article only that it is 4 millimeters is the normal, but if it is less than 3.5 in a term, then we consider it as subglottic,
yes,
suggestive
yes, yes.
stenosis.
Actually, the grade, see, we have different grades of subglottic stenosis. So it is a Cotton-Wear classification. So it's a grade 1, they're usually asymptomatic. It's just within the classification, but they're usually asymptomatic. When it comes to grade 2, grade 3, grade 4, grade 4 is like no lumen. So the grade 1, it is actually like a big grade. So grade 1 may not be symptomatic at all. Only when they have, when later in life, when they develop a croup or when there is some recurrent intubations needed, that is when this gets aggravated, and because of post intubation and the scarring, the grade 1 can become grade 2 when they actually present.
Okay.
Mild subglottic stenosis, they usually they don't present unless many kids they develop that is later in life when they develop this recurrent croup.
Okay. So
They
term
actually present.
maybe we should take 3.5 if you're not able to intubate with 3.5
Yeah,
as
yeah,
something
3.5.
suggestive of maybe that may be grade 1 or so, right?
Yes, yes.
That's what. Preterm it can be variable because we have very preterms also. Sometimes we have to intubate with 2.5 or extremely
Yes,
preterm,
yes,
sometimes
yes,
2
sure. Yes, yes,
millimeters.
yes. This is like this thing says that the diameter of the airway should be 3 mm in a preterm, and the diameter of the airway should be 4 mm in a term baby.
No, but
But a
how
tube,
much preterm, that is also question because we are intubating babies of 24-weeker also wherein we
yes,
have
yes,
to use
yes.
sometimes 2 millimeters ET size. So therein we cannot think of 3 millimeters. So that's a little bit questionable.
Yeah,
This
sure. And so
criteria.
we see, so that we had one case also. So this is a child, this is a preterm child with actually a laryngomalacia, sir. But usually, as I told you, laryngomalacia, they present only after 2 weeks. But this child actually had rainbow only. So had a like laryngomalacia picture, the full epiglottis was folding and the arytenoid was, this is not a fixed rule for airway. So we did a supraglotoplasty and we just did a balloon dilatation because the rigid scope we have, it is 4 mm or it is a 2.7 mm, two sizes. So this 2.7 mm was just a tight fit. So this 2.7 mm is the outer diameter, like not like ET tube, but then this 2.7 mm is the outer diameter. That's a rod shape. So this was not going. So I just dilated it off So that child's video only I showed. The next day, the child was like, immediately after surgery, we extubated the child and sent. The child was fully okay. So we just see whether along with this, we see if we feel the subglot is narrow, just balloon dilated it because like so nowadays we are getting really preterm babies. Then this classification came, and now we are getting a really preterm baby. So we see actually it's not like for all grade 1 stenosis we do this. It's airway procedures. There is no standardization. So we have to make a plan for each child and plan
Right.
the surgeries accordingly.
One very important comment for coronal atresia for all the participants who are listening is, apart from the CT and all, it can be very easily diagnosed by clinical picture also, because once the baby is born, and if the baby is not crying and then turning blue, but immediately as soon as the baby cries, which means opens up the mouth and then starts getting uh, pink or not cyanosed, then that's a very strong indication of a coronary.
Nose pathology.
And obviously, apart from CT, which is mandatory for the operative procedures and all, we can always insert an NG or an infant feeding tube, and if we are not able to pass through both the nostrils, then we should suspect as a bilateral coronal atresia and call the EAT persons ASAP. I think I can't see any further questions. So uh, this is quite a new topic, and all we can keep on asking questions from the expert. But I'm really thankful to the NNF team, for the NOEL team, for conducting this beautiful topic, which is vastly coming up and definitely challenging for all the neonatologists. So it has enhanced our knowledge, and I'm really thankful to Dr. Nitya for taking us through beautifully through this extremely challenging topic in a very short span of time, and giving us beautiful insights onto this topic.
Thank you. Thank you, sir. And hopefully, I think something useful has come up from this presentation.
Definitely, it has been.
Like whatever, like so if you suspect any airway pathology or any, there is some, you can actually scope the child in the NICU itself. That is very important because unlike older kids, like really like neonates, they tolerate procedures very well. So we just put a local and just towel roll them. You can actually go till the bronchus until like to know, and you get a dynamic and view in like 1 minute, 2 minute time. So
I do understand not every unit may have such beautiful resources available with them. So that's why I asked the question of CT and all. That can be certain times handy. And then obviously, if you are not getting anything, that doesn't rule out any airway or laryngeal pathology or so, you can refer them so for these procedures. So thank you. I think we can end, and I hand it over to Gunjana for any announcements or so.
Thank you, Satan sir, for accepting the invite as a moderator and doing 100% justice to it. And Dr. Nitya, I think it was one of the wonderful session. And I'll tell you, we during this complete session, we did have the maximum attendance of the NOEL. So it reached to the maximum. We even during a case presentation, OSCE and the various sessions we organize, we hardly get this much of attendance. So I think the people are really interested to listen to you. And completely new topic, as rightly said by Satyan sir, and many new things to learn. Not all of us are blessed to have a pediatric ENT surgeon and a specialist like you, but I think it's something very mind opening for all of us, that there are many aspects which are coming up which could be explored, and there are specialists which are coming up with all these newer techniques and the bedside procedures, which could be really helpful, specifically when it comes to the NICU and the NICU graduates. So thank you, Dr. Nitya. A lot to learn, I suppose, and a very great eye opener for many of us.
thank you, ma'am. Thank you for having me.
Thank
And
you.
thanks to Girdhar for this opportunity.
So thank you, everyone. We'll be ending with the session. So good night, sir. Good night, Dr. Nitya.